Alright guys, welcome back to the channel. Today's episode we'll do another Radiologist Reacts. I know it's been a while since I've done one of these, but work's been kicking me in the dick. But I'll try to be more consistent with these going forward. Before we get started, if you enjoy the content, please like, comment, and subscribe. You can find us on TikTok, Instagram, Twitter, and YouTube at rad_talk_DG. You can also find our podcast on all the major podcast platforms if you just search Rad Talk. So for today's video, I wanted to discuss the Aaron Rodgers Achilles injury that he suffered on Monday night. For those that aren't aware, he tore his Achilles roughly, a minute into his first game with the Jets. So I thought it would be interesting to give you guys a radiologist perspective as to how it is diagnosed and how it will help the surgeon treat Aaron going forward. For those that are unaware or haven't watched the channel, I am a musculoskeletal radiologist. So we are the ones that deal with bones, joints, tendons, ligaments, muscles, that kind of stuff. So we are uniquely qualified. And in this case, an MSK radiologist would have been the one that read Aaron's MRI that he got. So I thought it'd be cool to take you guys through the radiology aspect of it, because the surgical aspect gets a lot of attention, rightfully so. And then also the physical therapy gets a lot of attention, because we're going to talk about his his recovery for the next 12, 15 months, however long it takes. But I kind of want to just give you guys a brief overview as to what went down behind the scenes in terms of radiology. So what we're going to do first is we're going to watch a short clip showing the injury. So if you're squeamish, you might want to skip this part.
He goes down. Rodgers.
Oh, somebody! Oh, he needs some milk.
I've seen that plenty of times, and it takes all I have just to watch it. And it's not even that gruesome. There's no bone or anything, but just watching that thing snap, and you can see it reverberate up his leg. You just know how painful that was. So before we get started, there were a couple caveats that I wanted to point out about this clip specifically. Once you get this clip on Twitter, the Twitter docs were going crazy. Everyday people were trying to diagnose Aaron with whatever they thought was going on. I'm not a huge fan of trying to diagnose someone off of videos. I think the only one that should do that are the orthopedic surgeons. They're really good at it, actually, from what I've seen. But the point being, the surgeon's they're not gonna cut Aaron's leg open and fix that Achilles tendon based off of a Twitter video. So they need something to confirm it, and then that's where we step in with the MRI. And then secondly, this reignited a debate among the NFL players about turf versus real grass. The players are very much wanting to go back to real grass because the injuries have shown to be less. And I think it's because, don't quote me, but turf doesn't give. So Aaron's foot, as you see in the video on the screen there, is stuck. So it's planted in the ground and it can't go anywhere. Whereas if it were planted in grass, the cleats would dig in and maybe dig out the grass, throw it out, and his foot would move, therefore avoiding this type of injury. So we'll see, because he's a very prominent, very famous person in the NFL. So we'll see if this gets the NFL owners to kind of change their mind and go back to grass fields. So first thing I want to do is go over just some very basic anatomy. People always talk about the calf, but what exactly is the calf and how does it relate to the Achilles tendon? So the calf itself is just 4 different muscles, right? So you have your gastrocnemius muscles, which have been cut away here in this little cartoon, but you have a medial head, which just means the inner aspect, and then you have a lateral head, which just means the outer aspect. So you have those 2 muscles. You have this thin white line here, which is called the plantaris, and then you have this other muscle here, which is called the soleus. So those 4 muscles combined are what collectively make up the calf. And how does that relate to the Achilles tendon? Well, it's actually what forms the Achilles tendon. So these 4 muscles come together to form the tendon. As you can see here, it's called the calcaneal, more commonly known as the Achilles tendon. And those 4 muscles blend together as they attach onto the calcaneus, which is more commonly referred to as the heel. So tendon is just something that connects muscle to bone. So as we see in this image here, you have 4 muscles being connected to a bone by a tendon, as opposed to a ligament, which just connects bone to bone. So if you think of the ACL, that's the anterior cruciate ligament. So that just connects your femur to your tibia. So that's the difference between a tendon and a ligament.
Oh my God, who the hell cares?
The Achilles tendon is named after the Greek hero Achilles. His bitch ass mom didn't dip him in the river Styx fully. She held him by that ankle, therefore leaving that ankle exposed. It's also the longest and most strongest tendon in the body, so it takes a lot of force to tear just to do what Aaron did. It happens not infrequently, but it does it's impressive because it takes a lot of force. I read an article that said when you walk, your Achilles tendon can transmit 2 to 3 times body weight, the force of your body weight. So that's even higher when you run and all that kind of stuff. So that just shows you how much pressure you have to put on the Achilles tendon to snap it. What is the major function of the Achilles? I kind of alluded to it when with the walking, but there are many functions of the ankle itself. You have a lot of mobility at the ankle, but the Achilles tendon is specifically involved in what's called plantar flexion. So if you can kind of see here the guy's toes, what plantar flexion is when you point your toes towards the ground, or if you simulate like a calf raise or just standing on your tippy toes, that's called plantar flexion, and that's where the Achilles has most of its function at the level of the ankle. The opposite of that would be called dorsiflexion, which is where you try and bring your toes towards your nose, which is important, as we'll talk about how these injuries actually occur. So now what I want to discuss is kind of what happened with Aaron real time and how it pertains to imaging. So he goes down, he gets injured, he gets on the cart, they take him back to the locker room, and most, if not all, of NFL stadiums have X-ray machines in the back somewhere in the locker room. So the locker room area somewhere back there. So they take him back, and he immediately gets X-rays. So when you hear someone like Adam Schefter say the X-rays were negative, that's how they know so quickly, is because he gets them immediately. He doesn't have to leave the stadium for them. But the point of this is to say that X-rays are not very good for soft tissues like ligaments and tendons. What X-rays are really good for is bone. So I have just a normal X-ray from the internet. This is what Aaron would have gotten. Here you have this kind of dense white stuff here, which is just the bone itself. You have the lower leg, the tibia and the fibula, you have the ankle, you have the foot, and then this bone here that I'm outlining is what people commonly refer to as the heel or the calcaneus. The thin kind of grayish line here that I'm outlining is actually the Achilles tendon. So you can see the Achilles tendon on X-ray. It's just not really good for that. Sometimes if a tear is bad enough, if it tears the bone with it, or if there's a lot of swelling or something, you can actually see the tear on X-ray. But the point is that most of these athletes get X-rays that are negative. But that doesn't really tell you anything. It just tells you there's no fracture. But given the fact that most of the injuries are soft tissue related, you expect the X-rays to be negative. Okay, so then once you get an X-ray and you find out that it's negative, what is the next step? So the MRI is the gold standard for a lot of stuff that we do in MSK. It shows the tendons, the ligaments, it shows the bones, it shows a lot of stuff really well. But the point being, he goes in, he gets the MRI, and this is where the radiologist first comes into play. So we are the ones that determine essentially what type or kind of the field of view of the MRI. With the ankle or the foot specifically, it's broken into 3 parts. You have the forefoot, which is essentially just the toes. You have the midfoot, which if you ever hear of someone having a Liz Frank injury, that's the midfoot. And then you have the hindfoot or the ankle. So we have to make sure that he gets the field of view that he needs. So the surgeon says, hey, I'm worried about an Achilles tear. We know, okay, he needs an ankle MRI. Or the surgeon says, oh, we're worried about the the Liz Frank ligament. Then we give him a midfoot injury or MRI. So this is where we first come into play with, helping the surgeon and the patient get the right imaging. Okay, so what this image is showing you is a normal Achilles on the left and abnormal Achilles on the right. We'll start with the normal side, but MRI makes it easy. You can see a lot of things on MRI, but the nice thing is that ligaments should not have, for the most part, should not have any signal in them. The Achilles is one of them. It should be a nice, thin, dark line here. It should be less than 6 to 8 millimeters, and it should have no signal in it. So before we move on to more of the images, it's important to note that there are 2 major types of injury, and I will show you images of both. So the first type is what's called tendinopathy or strain, right? So in Aaron's case, I think there was a report that said he, strained his calf, 2-3 weeks prior to the actual tear. So what happens when someone is they have tendinopathy or there's a strain? You can see here, this image shows, if you go back to the normal image, you remember how thin that ligament was. This is thickened, so it's already abnormal. And then you can see here, I remember I said there should be no signal in it. So here's abnormal signal. This is what abnormal signal looks like. So this person has Achilles tendinopathy. And at this point, this is like a chronic finding. And what they usually do is just rest, conservative management. But what can happen if you don't is if you keep, using your keep overusing the tendon and all that kind of stuff, it can chronically tear. So there are two types of ways that the Achilles tears. This is the first one. It just chronically degenerates over time because you don't stop using it the way you should. You don't rest it properly, and it will start to break down, and over time will completely tear. And then the second one is what happened in Aaron's case. So once you get from tendinopathy to tear, then you have to decide, is it complete or a partial tear? I didn't read Aaron's report, obviously, but I assume his was a complete tear, which means the tendon was torn all the way through and both ends were retracted. If it's incomplete, then you have to decide how much of the tendon is involved. Usually we use 50%. If it's greater than 50%, it's called a high-grade tear, and they might go to surgery anyway. If it's under 50%, maybe they can manage it conservatively. Maybe he makes it back by the end of the year if the Jets are in like playoff contention. But for the sake of this video, let's assume it was completely torn. So you get the MRI. This is what it will look like. Remember, normal should be nice thin, less than 6 to 8 millimeters. I can't measure this, but I know it's greater than 6 to 8 millimeters. So this person they had tendinopathy. Then you have this white stuff here, which is fluid. So it's called a fluid-filled gap. That's how we know this is completely torn. So there's fluid between the two ends of the tendon. So it's important as radiologists to, one, incomplete versus complete, and then two, when you get to a complete tear, there are a couple other things the surgeon wants to know. They want to know how big is the gap. So are they dealing with a 2 centimeter gap, a 6 centimeter gap, whatever. They have to know how far, because when they're going to reattach it, they need to know how far they're going to have to go to reattach the tendon. And the second thing is they want to know what the underlying tendon looks like. So if you have what I assume, Aaron's tendon was probably a little more towards the normal side, whereas this person, it's very chronically thickened, there's signal, so he has tendinopathy. So that's important because it's going to be impossible for the surgeon to stick their sutures in the tendon and reattach damaged tendon back to damaged tendon. So they have to know what the tendon looks like so they can change their approach, for surgery and that kind of stuff. Because if it's damaged and they try and reattach it like that, it can make it tear more easily. So obviously I'm not an orthopedic surgeon, but the orthopedic bros can let us know in the comments, kind of how this would affect their approach to the surgery. Another important thing to know is, where does the Achilles normally tear? So there's one area where it most commonly tears, and that's called the watershed or the critical zone, and that's anywhere from 2 to 6 centimeters from where it attaches on the heel. And it's called the watershed or critical zone because there's just not a lot of blood flow. So it's a weakened part of the tendon, and due to the decreased blood flow, that's also part of what makes it difficult to recover, because you need good blood flow for tissue to recover. So that's why part of the reason why these recoveries are so long for these athletes, because these are high level athletes, so they should recover faster even than the normal person, but the Achilles there's just no blood flow, so it's hard to recover. The second spot that it commonly tears is it will tear itself off of the bone. But for Aaron's purpose, he had something like this, I assume, without seeing the imaging. So then lastly, a little bit out of my wheelhouse, what happens once, the radiologist diagnoses the tear, we tell the surgeon, the findings they want to know. What are the options? I've briefly mentioned if it's a complete tear, the surgeon's going to take over. They're going to go to surgery and do whatever they have to do to fix it. And then they're going to go on to do recovery, physical therapy for 8, 12 months, whatever it is. The other option is, if it's not completely torn, you can do conservative management. You can rest, ice, whatever. Just take the pressure off of the tendon itself to hope that it doesn't, progress to a complete tear. But other than that, I really don't know too much about the treatment options because I don't deal with the treatment aspect side of things. So if you are an orthopedist or a physical therapist, let us know in the comments kind of what the recovery looks like for this. That'll do it for today's episode. Hopefully you enjoyed the content. And if you would like to see other injuries, ACL tears, rotator cuff tears, labral tears, stuff like that, let me know in the comments, and I'd be happy to make some more videos on stuff like this, as it's kind of in my wheelhouse. It's what I deal with on a day-to-day basis. As always, if you enjoyed the content, please like, comment, and subscribe, and we'll see you in the next one.